So welcome everybody. It's an honor for me to be chairing today's session. So my name is Pilar Pinilla Dominguez. I am here in my personal capacity, but in my professional life, I'm the Associate Director of the NICE International Team, the International Division of NICE. And as I said today, I have the privilege of being moderating the 5th event of HTA in questions from Concilium Scientific. And today we will be covering HTA in low and middle income countries. So just as usual for the events on HTA in question, we have our distinguished panel of experts, Dan Ollendorf, Carol Lonson, Val Orban, and Eric Lowe. And today you will have me moderating today's session. And we also have a guest expert speaker today, Javier Guzman. So he is the Director of Global Health Policy and Senior Policy Fellow at the Center for Global Development. He has had a lot of different posts in global health, such as the Director of the USAID-funded Medicines, Technology and Pharmaceutical Services Program at Management Science for Health. And he has also had several posts in the Colombian government, in the HTA agency, IEDS, in the Ministry of Health, and also in INVIMA, the regulatory agency. So as I said, today we will be covering HTA in low and middle income countries. And just in terms of introductions, I will just say that, as we know, many low and middle income countries have historically relied on external support and funding to contribute to efforts to achieve universal health coverage. However, the current panorama challenged this framework with, on one hand, increases in healthcare cost in almost everywhere, and then on the other, we have reductions in healthcare budgets. And budgets have indeed been even more stretched as a result of the current COVID-19 pandemic. And that has also led to reduction in aid funding in many countries. Therefore, it is more crucial than ever that countries and low and middle income countries generate more health per resource spent, and indeed contributing to efficiencies in healthcare spending while still contributing to or having in mind the trade-off of equality and equity. And indeed, that can be achieved by applying evidence-based priority setting mechanisms and HTA as a tool to support fair and equitable allocation of scarce and limited healthcare resources is indeed a tool that can support those efforts. However, institutionalizing and implementing HTA is very challenging, and particularly for low and middle income countries can be even more challenging. First, it needs political will and also the commitment to support what it can be sometimes unpopular but evidence-based decision. Also, in low and middle income countries, there is a lack in many countries in terms of capacity and capability at both human and monetary levels. There is a lack of local data that can be used to inform the analysis required for HTA. Sometimes there is a lack of interest from different stakeholders in transparency and accountability principles that are relevant for HTA. And sometimes we also have over-reliance on HTA outputs from high-income countries that have very different healthcare systems, different epidemiological profiles, and different, indeed, decision problems that are looked at in HTA. And last but not least, as HTA requires multidisciplinary approach and participation of different stakeholders, sometimes vested interests within the different stakeholders can hamper the successful implementation of HTA policies. Therefore, today we would like to discuss why should low and middle income countries aim to institutionalize HTA? What are key problems and potential approaches that we can learn? Then we would like to move on to health system strengthening. What are the key steps that low and middle income countries should consider when embarking in HTA institutionalization? What are key elements for success, including cost of entry, infrastructure, supply chain issues that should be taken into account? Can we spotlight some good examples, and what can others learn from these? Then what should be in place in terms of political levers before implementing HTA, in terms of embedding those HTA outputs into access and adoption policies? And last but not least, we would like to discuss how have power dynamics impacted healthcare policy agenda in low-income countries, and how have these vested interests that we were discussing earlier from the different stakeholders handicapped sometimes HTA efforts in low and middle income countries, and how can these be mitigated? Finally, we would like to discuss how different are the challenges in low, middle, and high-income countries, and whether they require different health system strengthening approaches. What can be indeed adapted from other settings, and what can we all learn from each other? With that, I would like to invite, first of all, our guest speaker, Javier, to provide an overview of his point of view on these matters, and then I will invite the rest of our panel of experts to contribute as they will prefer. I will also encourage the audience to please raise your hand in using the reaction button, raising your hand in Zoom, and also to type questions in the channel, and I will bring you in when relevant. So thank you so much, and Javier, I will hand over to you.
Thank you, Pilar, and thanks to Consilium for the invitation. It is a pleasure for me to be here. I think it's a very timely discussion. It's a very interesting conversation, especially because, with the current financing climate, the key fact is that money is not going to be, money for health is not going to increase. So health budgets will be stable at best and might actually be cut. So it is very timely to talk about value for money. So I guess your first question is a question that really resonated with me in terms of the value of institutionalizing HTA for low and middle income countries. And I think there are just different entry points. There are different problems different countries want to solve when thinking or when using health technology assessment. You see, for instance, the experience of Latin America, and there's a very big move towards the right to health. So right to health and how to deliver on it. And then that was basically the key element or factor in making decisions on what's in and what's out of this right to health package. But if you see the examples of sub-Saharan African countries, sometimes the question is what should be included in the reimbursement list or the list that will be used by the central medical store, or what should be included in the essential medicines list. In other examples or experiences like India, for instance, physicians have been interested in improving quality. So, for instance, the National Cancer Grid, a network of hospitals, decided to use health technology assessment to inform the standard treatment guidelines and improve clinical practice. So the entry points are different, the problems are different, and I guess that is my first takeaway, which is what is the window of opportunity? What is, the angle, the entry point for this to be successful? Is it efficiency? Is it equity? Is it quality? Is it a combination of elements? Because my reflection is this is, as you said, a long-term plan. This is a process. Institutionalizing explicit priority setting is not going to happen overnight. You mentioned the importance of political will. You mentioned the importance of having, a good ecosystem that could be, put in place to deliver on this aim. But unless there's a very good window of opportunity and there is buy-in from the political leadership, I think it's very difficult to make progress. The current climate is a climate that is fit for purpose, I would say, because decision makers will have to, make decisions under a very challenging environment because of the macroeconomic situation I mentioned before post-pandemic with inflation and rising food prices and everything else. So I'll stop there as my first initial comment. Back to you.
Thank you, Javier. And I think that apart from the point that you made in terms of quality, efficiency, equity, you also made the point of, you introduced somehow within that window of opportunity concept, the role of the different stakeholders. You mentioned the politicians, you mentioned clinicians, you mentioned patients. So, and obviously you mentioned the HTA practitioners as well. So how we can all work with each other. Baya, I know that you have your hand raised. We'll hand over to you. And then Dan.
Thank you, Pilar, and thank you, Javier, for your reflection. I fully agree. I think it starts with political will. And of course, with the problem that you would like to address and whether or not HTA is potential, maybe partial answer to that problem, because I think not all problems that you mentioned can be answered solely with HTA. And I think the ecosystem is indeed very important. So a sustainable health system will leverage, I think, or will help also institutionalize HTA in a certain country. I also fully agree with this long-term perspective that people might think that HTA is the golden bullet, but without, having the foundation in a health system, HTA will not fly, I would say. And we always tend to forget that countries like, the UK and the Netherlands, where I live, are still developing their HTA system and optimizing their HTA system. And of course, when we talk about lower middle income countries, where I also work myself, people always want to move very fast, and well, that's not something that is going to happen. So I think you should also meet expectations and be very clear about what HTA can deliver and what it can't deliver and what you need for that. What I also wanted to say as a first reflection is mainly about the system's perspective as such. I mean, political will is one thing. I mean, that's very important, but I think it's also very important that the policymakers have a clear policy framework in place on which they can build an HTA process or an HTA system. For example, I'm now in Abu Dhabi and I work with the Department of Health, and they don't have a very clear policy framework in terms of what are the priorities, for example, and how that relates to the health needs of the population, even though it's very clear that efficiency here is the main problem, so cost containment is the main problem, and they would like to use HTA for that. But still, it's very hard to understand how that would work if you don't have a relevant policy framework in place that clearly articulates the decision-making criteria, for example, in relation to the values that are underlying the system. So I stop there as a first reflection. Thank you.
Thank you, Baya. And it's that link that you were mentioning between the output and the implementation. So Dan, what are your thoughts?
Thanks, Pilar. Yeah, really interesting discussion to start off. I think that the window of opportunity that Javier mentions really is an interesting way to think about it at this moment, because we are sort of facing a lot of financial challenges and austerity issues and health budgets in general. And I think that may be an opportunity for us as a community to really bring this messaging around the benefits of institutionalizing HTA home, in that without it, many investment decisions are made without a common frame of reference, without paying attention to the economic side of HTA. And Javier, as you've published yourself on, what that often means is that health is left on the table, that there's health foregone. And so the way to try to take what are going to be increasingly limited funds and apply them in as efficient a way as possible, in part involves HTA. The other bit of messaging I might think about would be borrowed, I guess, from high income settings when HTA evolved, And that, again, without a formal national commitment to doing HTA, decisions would be made in a much more decentralized fashion. Certain parts of a given country might have access to a new and useful technology while others would not, because of that decentralized decision-making. And so the benefit of a centralized approach would be that there's at least the opportunity for a national conversation about the potential for new technology.
Thank you, Dan. Carol, I know that you have also your hand raised. Can we get your thoughts as well on this?
Yes, thanks very much, Pilar. And I'm going to pick up a couple of points from each of Javier and Dan. So the window of opportunity, it's a really good framing for this discussion, because you have to think through what that window of opportunity might be in those different settings that we might contemplate, because they're different windows. I mean, if I'm thinking about it as a house, we've got lots and lots of windows of opportunity, and Dan picked up a couple, and I'm going to talk specifically about the window of opportunity that created NICE. And it wasn't really about the money so much. It's quite interesting that the foundations of NICE, yes, of course, NICE is well known for doing value for money assessments, but the political reason that NICE was established was the equity issue that Dan talked about. That in the UK there was not a system that allowed a person who's engaging with our National Health Service to be able to be clear what they could access wherever they lived. And that in a sense window of opportunity that was back in 1999 in the UK was a really important political lever for thinking, how do we introduce a rational system that allows people to be able to access new technologies, starting with drugs, new technologies, no matter where they lived in a national system. So if you're thinking then about transferring that concept across to different settings, you could start to develop in a sense, the window of opportunity framework for why a country might be interested in establishing what is in essence a set of tools, a toolkit, to enable them to think through how they might fairly equitably, economically distribute their finite healthcare resources. And I think that perhaps talking about the implementation of health technology assessment in that type of context takes us away from what tends to happen in these conversations, which is very quickly moving to the transferability of HTA processes from a high income setting to a low income setting. That never works. The principles might work, but actually we can discuss the principles without having to discuss the techniques. And it would be quite useful perhaps if we could explore some of those principles under the window of opportunity and why different countries might wish to use this fantastic toolkit that we have in health technology assessment. It might be quite a different way, perhaps, of entering the conversation.
Thank you, Carol. And I think that both Dan and you have mentioned the context and the importance of considering the context in which we are considering the institutionalizing and implementation of HTA. And the other thing that struck me from what Dan mentioned as well is the concept of fragmentation and decentralization, and how can HTA perhaps happens in different levels, and it still requires that political framework. So Eric, can I go with you for your thoughts as well?
Yeah, I'll be very quick because most of all the best points and good points have been made, so it's harder for me to say anything sensible. But I think for me, it's recognizing that while there's commonality in issues and challenges that health systems have, there'll also be very unique things within each country. So for me, it's about first and foremost of being very precise about what is the problem that needs a solution, and then to figure out if HTA is the solution to that problem or an alternative approach. Because I've often wondered in a UK context or in an England context, if NICE wasn't around, what would NHS England commercial team do? I think they'd get along just fine at making different types of decisions around what's paid for, what's not paid for, and how much we kind of pay for it. So I think there's around, is there an alternative solution to HTA, or is it some sort of hybrid type model? And then what type of HTA? And I just pick up on Carol's point about equality and equity, because for me, they're two different things. So what equality is all patients or all members of the public get access to the same healthcare. Equity means that healthcare is customized and it's specific to your needs, whether they're social needs, health literacy needs, or disease needs. So that would say if you have a particular type of aggressive cancer or a rare disease, then you might need many, many more resources than another patient from that same cohort. And that for me is where HTA falls down a little bit, is the equity bit, because it's not very good at customizing and reflecting individual patients in the real world. It tends to be, at least from a UK perspective, a kind of one size fits all, irrespective of your risk factors and irrespective of your personal preferences. This is what's been shown to be cost effective. This is what you're going to get. Two other quick points then is that low and middle income countries can learn what's been done well in other HTA and what hasn't worked and benefit from that. And at the end of the day, my final point is HTA assessment and appraisal is dependent on inputs. If the inputs aren't appropriate for the decision context, it's very hard to get the right decision. So we need to be clear, where does the evidence come from upon which low and middle income countries are making their decisions? Because if it's coming from a US-based study for the FDA, it's going to be really, really problematic, because it's already problematic for the UK and France and the Netherlands, never mind low and middle income countries.
Thank you, Eric, and thank you very much for bringing the discussion in terms of equity and values. And I guess that's the other factor that both Baya and Dan, I think, that we're referring to, is what are the factors that should be considered of value, and that's something that may well not be transferable across different jurisdictions. Also making the point about HTA answering specific questions, but not all the questions. It's not going to solve the problem. It's not going to solve health financing per se. And then the very important issue about transferability of inputs. So I would like to get another round and then perhaps move to another question. But before I do that, I know that one of our attendees have her hand raised. So Rosanna, thank you for raising your hand. Would you like to come in to make a point?
Yes, Patricia. Just to emphasize the relevance of nowadays, we need to land. We need to be more effective if we are talking about effectiveness, and making more visible the value of HTA. These are the time. This is the day. These are the days, and this is the time for us to make it not just visible, but the value. And the best way for me in the context I am working with, not just with Latin America and the Caribbean, but also with Bangladesh and others, the best way in this context, critical context globally, but LMICs mainly, is to be able to demonstrate this HTA has a value in specific topics like health, equity, and nowadays resources, infrastructure. We need to be able to transfer not just knowledge, but ways, frameworks to the decision makers, mainly in the government, that this is a knowledge and framework that is able to bring changes in this quality of services, accessibility to health organizations, and almost the sustainability, economic sustainability of the health organizations and the health research organizations as well in the government. because there is the main area on which the stakeholders, which are the decision makers, are taking the decisions. The other aspect is what I agree with the colleague when she said that it's time also to stop to think about the methodologies to implement HTA. Yes, I know in the past and even now we are focused on the discussion of which methodology, nice methodology, a European one, etc. But beyond that, the transfer of knowledge about HTA value, the impact measurement, once we apply HTA, is key to be transferred to the decision makers, and in that regard, multidisciplinary members in the government on the side between not just the expert, but expert which has been working in the site in different contexts. In this regard, we will be able to show HTA beyond a philosophic or scientific, but so far from our reality discussion, etc. Thank you very much, Patricia.
Oh, thank you so much, Rosanna. That was really insightful, and I think that you made a very good point about something that we should do better. And I think that sometimes more established HTA agencies have failed somehow to show the impact of HTA in a more systematic way. Yesterday I was reading actually a paper on the value of HTA in Thailand, and an approach to actually quantify that in terms of health. So you know, it's so important, and it's such a powerful message to actually show the importance of HTA and the value and impact of it. Carol.
Thanks. One of the things I want to pick up from the previous speaker is this concept of process or procedure, because I think it is one of the universal capabilities of health technology assessment. No matter how you do it and how you apply it, what HTA allows is to have a structure, a procedural structure around making decisions, and that is absolutely universally transferable. And it is one of the things that I found when I've gone around talking to different people from different countries, government officials, or at meetings. We get very quickly into the methods of HTA. Should we use QALYs? Should we not use QALYs? You know, how does NICE cope with so much data? But we skim very quickly over what really matters, which is how to build a process, a procedural structure that allows a decision maker to feel comfortable with making quite difficult decisions about universal coverage, maybe, or whether or not a population is going to have access to an individual technology. That procedure, the way in which you do it, not just how you do it methodologically, is so powerful. And of course, depending on how comfortable you are as either a decision maker or a jurisdiction, about how far those ripples of procedure go, you can build layer upon layer of procedural inclusion, if I could put it that way, with your stakeholders, with different types of perspectives, and it starts to then build up a very, very important conceptual framework that NICE has used right from the beginning, which is accountability for reasonableness, which is one of the underpinning, I suppose, it is philosophical tenets of the way that NICE does things, is that if you can explain what you do and why you do it, so not about the decision, but how you go about undertaking decision making, and if you can give people the chance to at least question the way you're doing that, what you have embedded is a really important social grounding for health technology assessment itself. So I've absolutely not talked about methodology. because we go too quickly into methodology. I'm talking very much about using HTA as a powerful tool to improve the process of decision making, and a powerful tool to improve the inclusivity of that decision making itself. So I just don't know. I don't know if any others would like to comment on that, but I found that is an extremely important part of HTA.
Sure, thank you, Carolis. Without the principles, the methodology will not achieve much. So Javier, I think that you're next.
Yeah, I wanted to comment on that point about process and decision making. And I very much agree with the potential benefits. The flip side of the conversation is how policymakers are often not very keen to get into explicit priority setting, and how there is the need to have demand from society, sometimes organized civil society, sometimes just citizens, sometimes just the system, because oftentimes it's easier for policymakers to just say, and we've seen that everything is covered, health is a priority, and then you get into implicit rationing, and you get into stockouts, and you get into everything is covered in theory, but nothing is covered in practice. The big gap between the announcements and the reality. So I do very much agree with the benefit. I just see that sometimes it's hard to get policymakers to be restrained to some extent or open to share some of the decision making with other stakeholders. Also, I think if we talk about a continuum in terms of how systems mature and how systems grow, participation is something that is not top of mind when you get into these priority setting, HTA, institutionalization strategies. We do provide a lot of technical assistance, and oftentimes is, give me the evidence to make decisions. And when we talk about, and shouldn't we invite, incorporate, get others to help appraise the evidence or help, inform the decision, in a lot of cases, the decision makers are not interested. So I see that as a key challenge, and something that again is a long-term process. And to some extent, we're talking about the rule of law here. We're talking about bigger issues of governance, bigger issues of democracy, and things like that. Over. Thank you.
Thank you, Javier. And I think that might be also a reality in some high-income countries as well. Vaya, would you like to comment?
I think Dan was first, so I give.
Oh, sorry, Dan.
My
apologies.
Vaya, go ahead.
Oh yeah, well, I just wanted to reflect on what Carol said and also Javier said in terms of process. I think, what we see, and I was talking from my own profession in terms of trying to help countries institutionalize HTA, and especially in low and middle income countries. And my colleague Kevin has also raised his hand. But we do use a procedural framework for helping them in terms of thinking about how to use accountability for reasonableness in setting up the whole HTA system. So we also, I also see HTA not only as doing the assessment, but the whole process of institutionalization and governance and priority setting and identification of topics and monitoring and evaluation. And I think that is indeed what you also said. The monitoring and evaluation of how we implement HTA has not been the best. We have not been the best in doing that. And in terms of the accountability for reasonableness, yes, that is a theoretical framework. And what we have tried to do is to translate that into a practical guidance, or what we call evidence-informed deliberative processes. And we are implementing these now in different countries, and we are very successful doing this in Pakistan and Iran. Now I'm in Abu Dhabi, in the Emirates, but we also do it in Moldova and Kazakhstan, Ukraine. And we see that there is political will for obtaining at least some transparency in the process, but also in terms of involving different stakeholders. And I think what Javier was saying, yes, in some countries it's very hard to involve stakeholders because they are not organized. For example, here also in Abu Dhabi, there is no patient organization, for example. There's no umbrella organization, and patients are not yet, organize themselves in order to give them the floor and how to involve them then in also all these processes, and also how do you go about vested interest of different stakeholders. I think that's very, very difficult, and I think that's also part of HTA. HTA is first about the process or the principles, and of course the methods come with that. I mean, that's the technical expertise, and often countries also lack technical expertise, and how do you go about that? But without this foundation of indeed the procedural framework or framework on how to institutionalize, I mean, you can have methods, but then it doesn't make any sense. So I think first you need to have a foundation on which you can build all the different layers indeed. And that's very, very hard work for the countries themselves. Because look what Javier was saying, some countries do not have a tradition of using evidence in policymaking. So how can you then try to, show that this is the way forward? And sometimes it's a very long journey back and forth, like in Kazakhstan, where I've been working since 2012. It's back and forth. It also depends on the government that is in the position to make these decisions, right? So sometimes you have I would say, a more open government that is more open or prone to more deliberative decision making, and sometimes you have, governments that are, more strict in that sense. So I think it also depends on the political cycle, and that makes it sometimes hard for us to do the work, and especially for those in the country, of course. So I think this political link to the political cycle of politicians, I think, is some countries very important. So that's what I would like to bring into the discussion. Thank you.
Thank you, Vaya. And I think that your experience resonates with mine to a certain level, where it's very tempting somehow from the governments to try to just avoid that step. And, the need to bring forth that step cannot just be avoided and pretended that it's okay when it hasn't been actually tackled. Dan, really sorry again. Please come in.
No need to apologize. Lots to react to here. And I guess one of my reactions could be when Javier and Vaya talked about governments not listening to the evidence that's presented, or everything's approved and nothing's actually funded. I could say, welcome to the US, where we share many of the challenges that we're talking about today. And in fact, maybe there's some lessons learned for the US as well as we talk through this. Talking about process, it's interesting. I'd have to say, in my prior role as a chief scientist for an HTA organization, I probably spent about 35% of my time on science and 65% on process. The importance of process is not just that you're documenting exactly how you go about doing things so that it's predictable for stakeholders, but that you're identifying opportunities for stakeholders to engage directly in the process. Time and time again, stakeholders, in particular patient groups, tell me that the benefit is not knowing about the process and knowing when to engage. It's that somebody is speaking with them and listening to them, because oftentimes they're feeling as though decisions or recommendations are made without their input. So I know it's kind of skipping ahead to some of the keys to success, but one of the things I jotted down as I was reviewing the slides was formalization of HTA really involves thinking about getting ahead of certain issues that are going to come up. And we've touched on some of them already. One is how to embed outreach to stakeholders and have them be as involved in your processes as they can possibly be, including, I might add, some of the deliberative aspects of HTA that Vaya was speaking about. So there actually are some very good examples in middle income settings of interested stakeholder groups, whether it's patient groups or citizen groups, being involved in deliberation to try to provide input on some of those equity questions that Eric brought up. Another, and I think HTA in high income settings has struggled with this, is getting ahead of what special cases might come up, what areas deserve special consideration, so that if in a particular society there's a great degree of value placed on therapies for extremely rare disease or therapies for cancer, the issues that we've all dealt with in high income settings, that those special considerations are documented and clear at the outset rather than having to play some sort of catch up later. And I think that Carol mentioned the accountability for reasonableness framework. I think touching on something that Javier brought up, if in a particular setting where there are political challenges, perhaps extending that framework to some of the stakeholders who are then involved in turning a recommendation into a decision is something that's required. So if we think about many middle income settings either have decentralized health authorities, multiple payers, or both, then if a central HTA body is making a recommendation and one of those organizations decides not to adopt that recommendation, they should explain why. They should be very clear about why they're not adopting the recommendation. And so that's really an extension of this notion of accountability for reasonableness and explaining your rationale.
Thank you, Dan. Eric, I would like to go with you, and then I will bring the question from the audience.
Thanks. Just a few points. Again, just picking up on what others have said is, I guess, in the absence of government setting healthcare priorities, or in the absence of healthcare systems and the components of health systems setting priorities, it kind of comes down to who shouts the loudest. Seems to get a disproportionate amount of the scarce resources. You know, Dan mentioned cancer. You know, so we know that the cancer lobby is massive, both on the public side, the patient advocacy side, and the industry side. But we know that the very vast majority of cancer drugs bring tiny, tiny benefits. You know, very, very small. We've discussed that in previous webinars. So I guess what I'm saying is that there needs to be some degree of prioritization, some framework in which to work. Otherwise, you know, whoever shouts the loudest or has the biggest voice in low and middle income countries will kind of win. The other kind of point is always to be mindful that HTA, I guess, is a point in a continuum from bench to bedside. It's not the final point, and that for HTA guidance to be relevant in the real world setting, to be adopted and implemented, takes resources, it takes systems, it takes pharmacy, it takes data collection, it takes education, it takes, you know, prescribing training, monitoring. There's all kinds of things that come after HTA that if they're not in place, you might as well have not done the HTA at all, because the health system will continue to buy costs and not outcomes. And then just to pick up on a point that Dan had made also is, where does the PPI come in? Because even in England and Scotland and Canada, it's still very difficult to do patient involvement in HTA. The opportunities are there, but often the sophistication of the advocacy isn't what HTA needs. And I've said this before on our previous sort of webinars. If patient advocacy wants to impact on HTA decision making, it's much easier to influence the evidence development. It's not easy to influence evidence development, but that's where you want to have the biggest impact on HTA, is making sure that the inputs that are going to be appraised and assessed are the best they can be. Because if they're not, patient input has marginal kind of benefit. So just some other things to think about in the discussion.
Thank you, Eric. And I think that point about successful involvement is crucial. I know that we have a question from the audience, and I would like to bring Gavin into the discussion. Gavin, will you be able to unmute yourself?
Hi, I hope you can hear me. I think first off, it's a bit of a challenging topic to discuss without having adequate representation from low middle income countries and ministries here, just to better understand some of those barriers. And those barriers are huge. I think two of the points I wanted to raise, how can we as a group help these countries? And one of them is data, and the second is access to training online. And when I say access, stuff that's freely available. And that's something we should really do better at. Someone said a point about, nice, and it's not about money. And I totally agree with that, because in Tanzania, it's not necessarily about money. It's just about the structures and the will of doing it. There are a lot of entry points to get in. Someone also said something about decentralized system and that making it challenging. But for me, that's been the window to say at a district and a region where I'm working with them, they know, and they've asked for help to implement, some sort of prioritized list. And in setting that list, it's actually almost impossible to access data. There's a lot of data out there that's around, complex combinations when it comes to diabetes and treatments, but actually they just want to know, looking at metformin, where should that be on their list? What are the cost effectiveness? How do other countries have that, and where is it prioritized? And there actually is nothing easily accessible out there. So they're sitting there, they're wanting to prioritize and trying to look for this data and help them find that data. It's nearly impossible. I'm not so sure that these procedures are actually so transferable. In two of the different countries I've been working on and developing their processes, we've changed them so many times. I think what is most important is, and this is what I've emphasized here in Tanzania, it's if you can substantiate your decisions and if you have a reason for those decisions. Another point was on the resources, where those going to come from. I don't think there's an issue of money here. There is no money, and that's agreed. It's around human resources. There just aren't people. So one of the people I'm working with, he's an anesthesiologist here. There's 70 in the country, and he's keen to work in HTA, but I know if he starts working in HTA, there's going to be 69 anesthesiologists in the country. So how do you kind of push that? What are, our budget constraints are, it's $2 per capita in terms of medicine spending. That's what we're trying to, those are the realities. So I know there's a push to establish HTA and institutionalize HTA, but it's really thinking about what works for the country. What are those entry points? Can we start prioritizing with the few key areas? And can we help the country or even the region save some money to get there? And the goal should be getting more money for health and less about getting value for money for establishing HTA as a broader unit. So I think we have a responsibility to see, can we make our data more accessible, and can we push our countries to actually freely providing that data, as well as saying, we're a developed country and we have a lot of resources behind us. Can we, give our courses for free online for those that need it? And that's my little piece. Thanks very much.
Thank you, Gavin. I think that you made a very powerful comment here and very good food for thought for all of us. And I know that in the audience, actually, you mentioned diversity. I've spotted in the audience that we have representation from many countries today, which I'm very grateful for. So I invite everybody to contribute as much as they want. But before we do that, I would like to come to Carol. So please, Carol, come in.
Thanks. And Gavin has given us the challenge of getting real and getting practical. and not theoretical. And it is a really important sort of check in the conversations. And I was just thinking about that before Gavin put his points across, and thinking through some of the situations I've been in over the years, where you've got a politician in front of you from another country who's interested in talking about what NICE was up to and what its process is, and so I'm just giving you a couple of insights into some of those conversations. Once when I started talking about process, their eyes completely clouded over, and they stopped listening, basically, because it sounded really boring, and it sounded something that isn't going to solve their problems, talking about HTA processes. But there were one or two little tricks I had up my sleeve that did tend to keep their eyes open. And one was a process that takes away difficult decisions and gives you justification for the final decision you're going to need to make. Seem to go down extremely well. The second sort of point that tended to still keep their eyes open was that having a structure around these decisions means that you probably can develop something that is really efficient and relatively low cost, because you probably can borrow information from other places, as long as you have a process that's tailored for your jurisdiction to then internalize that and make the decision. So I've got them into talking about process, really via talking about either making it easier for them personally in their political life, or making it efficient for their department, because we can develop a very streamlined process that allows you to use all of the information that's out there. I do accept the fact, you're absolutely right, Gavin, that it's sometimes really difficult to source information from other jurisdictions in a way that's easily transferred into another place. But I'm just wondering if perhaps again some of the barriers to the institutionalization of HTA is because the way we talk about HTA itself. And I'm just wondering if there are different ways to be able to explain the usefulness of HTA that resonates much more in the jurisdiction that you're talking to, rather than the language we tend to use, which is about, I've done it myself, accountability for reasonableness, fairness. You know, it doesn't tend to always go down very well.
Come back to the point of showing the value, isn't it? Javier.
Thank you. Just wanted to comment on the point made by Gavin on revenue generation versus allocative efficiency, and I think it's not an either or. I think there needs to be, additional money for health, but there should be, a good explicit systematic priority setting to improve allocative efficiency. But I do take the point that I think it's very hard, and I think sometimes questionable, to talk about priority setting when you're talking about very necessary, cost-effective, essential interventions. So are we sacrificing, elements that are essential for a health system? And that is clearly the case when you talk about very low-income countries and you talk about health expenditure per capita of less than $50 per person. There's been some work by DCP in terms of assessing the cost of essential benefit package, the essential bare minimum, and it's $79 per capita per year. So if you talk about health expenditure lower than that, you're talking about sacrificing things that should not be sacrificed. So that is a key element that should be, in the conversation. Now, how do you work under those difficult constraint scenarios? Because the decisions will be made anyway. So one could argue that priority setting is still relevant even in those settings where, you know, expenditure is low and difficult decisions will be made. So I understand that angle as well, but I just wanted to say, you know, the importance of, yes, revenue generation and the alignment that needs to also, should also happen with allocative efficiency. Thank you. Over.
Thank you, Javier. Dan.
Yeah, so at the risk of sounding too much like an advertisement, I think there are some things that could help, certainly in the kind of situation that Gavin was describing. There may be opportunities to identify courses or modules that could be freely available to individuals on the ground in a given country. There are repositories of information on the cost effectiveness of interventions, and those are numerous. DCP3, WHO Choice. My own center at Tufts has recently revamped its cost effectiveness registry and is making the information available for free to LMIC researchers and policymakers as long as they fill out a research agreement. So what's been evaluated in other settings, and of course, you know, there are some caveats around that because cost effectiveness studies are funded by a variety of sources, and it's often the funder's agenda that they're addressing rather than pure priority setting needs in a given country or region. But there are some resources available. In addition, while there are lots of challenges and concerns around the idea of adapting HTA done elsewhere to a given setting, there has been some movement in development of methodology to really think very concretely about what can and can't be adapted for similar decision problems in different settings. Pilar and I have written previously about the idea of virtual HTA, which is really the sense that if a given set of policymakers or government officials has the sensibility to do HTA, but there just are not bodies on the ground to do it, there could be an extended team from elsewhere to help with that process. It could be, you know, a couple of situations that relate to proof of concept, or it could be a more involved process as well. So I think there is the potential out there. Certainly proceed with caution is probably the idea in all of these circumstances, but there are resources.
Thank you, Dana. I think that we are moving to the more concrete actions in the discussion. Vaya.
Yeah, I also wanted to say a few words about training, and Dan also mentioned a few sources, but I think training is key, and capacity building is key. And although there might be online trainings, I think, of course, it's also about using that expertise on the ground and build local capacity as much as possible. And for example, Kevin was referring to his experience in Tanzania currently with this person involved in HTA. But for example, now here in Abu Dhabi, I ask about the expertise in health economics, and there is only one health economist here in the country, and they don't have the capacity. And I was also asking about training opportunities in terms of what kind of curriculum do they offer at the university, and there is well, of course, there are training opportunities in clinical epidemiology, for example, and in public health, but not in health economics. And I think there's also something that we tend to forget is the link to students and to curriculums in the country itself. So we tend to think in terms of HTA that there is no link with educational programs. And I think we could also try to change that model, that we also need to invest in local capacity building in the countries themselves, linking HTA expertise maybe from our countries, so other countries providing master programs like ourselves in my university in HTA, that we could also work with other universities in other countries in trying to provide training online, and potentially that could be, you know, partially free of charge, to do train the trainers. And for example, we are now going to do this with the HTA department in Ukraine. So we will do a train the trainers, so they will build the capacity through the train the trainers in order to teach their own people the HTA department. So I think there are more and more options to share expertise and to learn from each other. And that brings me to another issue of training, or at least sharing experience. I think also those, say, policymakers or departments of health who are interested in, setting up HTA programs, or at least use HTA, or how we would use it, call it. I think that we should also, as an HTA community, have the responsibility to use our own networks and bring these people into contact with others in order to learn from each other. Those, for example, in the region or in the same situation, so that they can share expertise and, use that learning into their own practice, because it's not up to us to tell them what to do. But I think if you talk to a person in another HTA body or in a department of health with the same problem, it might also help you at least to understand what the challenges are, and they can also give maybe practical solutions. So I think the sharing and the learning and the capacity building can go hand in hand with the universities, HTA community, as well as with the policymakers. And at least that's something I really would like to bring across. Thank you.
Thank you, Vaya. And I think that both Don and you have made a very good point that sometimes we take for granted, and it's the important links with academics and with academia. And, in some contexts, like in the UK, without that support, there will not be much that we will be able to achieve. And, when you don't have that body of academic networks already in place, it's very difficult to draw about the little capacity that is on the ground. And the other thing that I think that you pointed out very rightly is the emergence of networks of people having the same issues, and the value of those connections in terms of advancing on HTA. And I think that now more than ever, we are seeing more of these networks happening and taking shape, and hopefully bringing value to the conversation. Actually, I've just seen that comment on the chat as well about UNEDA and about the collaboration between high-income countries and middle-income countries. And I just wonder whether perhaps you, Vaya, or anybody from the panel would like to comment on that. What are the lessons learned from the start of UNEDA 21 and the collaboration between high-income countries and middle-income countries, and whether that will be documented? Will anybody like to comment on that from UNEDA perspective?
Pilar, I think it's too early to know. It's literally only just started, hasn't it?
Yeah.
But in terms of inclusivity, of course, that has been the beauty of the UNETA initiative all along, and all member states within the European Union were able to join in, irrespective of their own internal capability. And I think that has been one of the most important features of UNETA. And it's something that isn't really, again, another thing that isn't really talked about. But you learn so much from understanding both the opportunities, but also the constraints that are in different places, about how you might do things in your own jurisdiction, irrespective of the resources that you have available. Because we always tend to have a mindset that is totally framed from the jurisdiction you're in, and it is only by talking to others about what they're doing, how they're doing it, why they're doing it, that you can start to reframe your own way of doing things. And I can absolutely say that there have been many things that having a conversation with international colleagues and then taking that back into NICE over the years has been profoundly important.
Yeah, it's demonstrating that value that brings back on those exchanges that is really important, as you said, Carol. Lydia, I know that you made the point, and would you like to comment on the point that you made?
Yes, exactly. I would like just to ask maybe to Wia, how can we make sure that the process will be documented? Because you're fully right, it's really just starting up, and I've heard tenders are out there. So maybe it's not now the right moment to assure that that the whole process will be documented, because I'm not sure that will happen. Just a question.
Well, I'm not involved in UNETA HTA 21, but we can talk to the person in charge. So that's not a problem. But I think it's a good point, and I think I think it would be great if if you just send them a message and asking them about this, because I think if we don't speak up and ask whether or not this will be documented, then they might not think about it. So I think it's a good idea. I fully agree, because like I said before, I think, we tend to do things and we do not measure any impact. We do not think about the potential value of HTA, of even in terms of what value collaboration means. And then we forget, and then suddenly, it's over and we haven't set a baseline. And I think the baseline is very important, and also what we try to, or what we collaboratively would like to achieve, and monitor that this along the path towards that goal, and see whether or not the strategy needs to be adapted. So I think that's what we would call an impact pathway. So I think it's a fantastic comment that you make, and I will note this down, and maybe we can talk to Nicholas to see if he can take this on board. Thank you.
Thank you, Lydia and Maya. Javier.
Yes, I wanted to talk a bit about networks and about the role of regional platforms. The first thing about networks is, I think it's important to be clear about the aims and goals of each of the networks. We've seen networks of course, in Europe, but in low and middle income countries, we've seen HTA, Asia Link, we've seen Redetsa. And I think the lessons learned are many in terms of what works, what doesn't, how you maintain momentum. At the moment, we are in conversations with one of the IDSI partners, Cambry. They're very interested in creating the Afro HTA network. So it's a process that is actually happening, and we are really interested in learning from all those lessons from the different networks. Now, in terms of the conversation on regional approaches, there's always been this, I guess, challenge and limitation that it is difficult to do assessments at the regional level. These decisions are made at the national level. And therefore, capacity should be created at the national level, and that makes sense. But at the same time, we cannot deny this reality that the regional platforms are getting a lot of traction, and the decision making is actually taking place at the regional level. And regional approaches might be a way to leapfrog and move quickly to having some capacity. You cannot create. You should not, and you don't want to create a NICE in every country of the world, as much as you don't want to create, an FDA or an MHRA in every country in the world. So what is the role of regional approaches? We, for instance, are supporting the African Union and the Africa CDC. They've created the health economics program, and the idea is to, provide, the continent with a platform that is supportive and can provide guidance. And guidance could be about methods, it could be about approaches, it could be about topics, but it could also be about partnering countries to do assessments and informing each other about the best way to solve issues. So I think regional approaches will be more relevant going forward. We've seen how the decision making is actually regional to a large extent in COVID, for instance. So that's something I just wanted to bring to the conversation. Thanks.
Thank you, Javier. And I think that resonates with everybody's aim at the moment, how we can collaborate and how can we collaborate better. What are the things that we are all doing and how can we create efficiency? And sometimes you may think, and as you were pointed out, perhaps we should learn from some low middle income countries that have organized themselves to do so, whereas we haven't been able to. Vaya.
Thank you. Yeah, I like the point that Javier raised in terms of regional networks. And of course, Asia Link is a voluntary network, and they do not have any resources that support networks. I think that's one of the barriers for the Asia Link. At least that's what they have published about themselves, and also what they have told me. So I think the purpose of networks is, of course, in Asia Link is information sharing and organizing conferences together in order to share experiences. And I think we could distinguish between information sharing or doing assessments together like the UNETA, or maybe doing other types of HTA activities like horizon scanning or using horizon scanning to inform pricing and reimbursement decisions. For example, that is undertaken in Europe by, for example, Benelux initiative, and there are a few more. But even though there are some more networks or collaborations between countries, sometimes these are not very effective, or at least they have not done anything. So it's sometimes also more for, I don't know how to say this, but it looks more like a marketing tool or something. Okay, we intend to work together, but we should not forget that also collaboration could be challenging, and also UNETA also showed that it's not always easy to collaborate in terms of the national mandate that countries do have. So I think we maybe make a distinction between information sharing, experience sharing, and doing jointly assessments or other activities in order to have more countervailing power, for example, in terms of doing negotiations with industry. And Carol, maybe you can also talk about, or maybe also Eric can talk about the UK, in which different HTA bodies now work together with the regulatory authority as well as with industry in order to accelerate innovations. I think that there are many ways of collaboration, and I think we could maybe identify all of this, and what maybe also in terms of effectiveness, what is effective for what? I mean, collaboration for the sake of collaboration, I think that's not the way forward. I think we really should think about what is effective collaboration, how can we support that, and what is each other's role in this. Because without any resources, for example, Asia Link, they really struggle with moving the network forward, like with Redetza, which is unlike Redetza, which is supported by PAHO. The secretariat is hosted by PAHO, so they have more resources in terms of doing things. So I think that we should not forget that resources also there can be a leverage for these networks. Thank you.
Thank you, Vaya. And I think that it's also the importance of those collaborations supported by, you mentioned resources, but also the human resources that needs to be committed to actually collaborate with each other. And sometimes that's not there. And we don't necessarily have the people who will then sit down and will do the actual collaboration. We do collaborate, but not in practical terms sometimes. So Eric and then Dan.
Yeah, why I made all the points I was going to make, except she did it much better than I would, so thank you. I think that there's lots of potential in networking and collaboration, but again, it needs to be clear about why and what's the objective, what's the problem it solves, and what type of collaboration, is it information sharing, etc. And I think, again, why I've kind of made the point is that there's a difference between the appraisal of the evidence and the assessment of its value. And that's obviously done at a local, the appraisal part is done at a local level. And there's all kinds of factors that will influence willingness to pay thresholds, for example, in different jurisdictions for different reasons. And these decisions are time sensitive. It depends what else is happening in that country at that time. what else is happening in the economy, legally, politically, who's shouting the loudest, all kinds of things will impact on a country's willingness ultimately to pay for any new treatment that has been assessed through an HTA body.
Thank you, Eric. Dan?
Following on Eric's point, so I think we do need to think again about the decision problem that we're trying to solve here. So with regional networks, feels to me anyway that it'd be much more complex to think about regionally coordinated essential benefit package design or refinement. But when you're in the realm of single technology assessment, I think the benefit of informal networks is certainly already there. If there's something more formalized, that's really a statement to the fact that a sponsor, a manufacturer, is producing one package of evidence globally, just one. So it's the same evidence. And it is something of a duplication of effort to have multiple syntheses of that same body of evidence. And if there's a way to think about what could be coordinated regionally, what should be left to the individual nations to do on their own, then that's potentially a way forward. The other linchpin, I think, for a successful regional network is tying it to pooled procurement. So we have examples of this in high income settings for sure, but that I think is an idea that if there are joint clinical assessments, maybe with individual economic evaluations, but that all rolls into a pooled procurement exercise, I think the benefit of that wrapped all together to participating countries is pretty self-evident.
Thank you, Dan. Oh, and that brings, I think that comes back to the example that Vaya was mentioning with the Benelux, for example, initiative, but that also links into an issue that has been mentioned in the chat about transparency and willingness to how much transparent we can or want to be. But before we come back to transparency, Carol, I would like to come to you first.
Yes, and just a couple of additional points on collaboration, because many of the things that I might have wanted to say have already been done very eloquently. And again, just touching on the experience perhaps of NICE when it was in UNETA, and of NICE now as it's collaborating post-Brexit with its nearer neighbours in Scotland, Wales and Northern Ireland. The first thing is absolutely deciding why you need to collaborate is key, really key. And for both of those examples, it was about avoiding duplication, or it is about avoiding duplication, and a little bit about scarcity, that there's a finite resource even in those countries that have, very well developed and people may feel very well resourced health technology assessment capability. There's sort of it's a limitless demand once you get going. So both of those were around avoiding duplication and scarcity. But even so, when you've understood the reason of collaborating, it is a very labor-intensive thing to collaborate on meaningful activities. And so the point about having to think about resourcing the collaboration is absolutely essential. Because we've certainly, when we started with our interaction with the UNETA, or NICE's interaction with the UNETA initiative, we had no idea just how much effort we needed to put in to make the collaboration work really well, and to get what we needed ourselves as an individual agency back from that collaboration. So a lot of thinking, as well as a lot of physical effort. Exactly the same with the UK collaboration. NICE is sort of hosting the secretariat, which isn't really a secretariat. It's a very small amount of a person's job at the moment, but even so, really important. The final thing I would want to make, so firstly, you have to know what you're collaborating about. Secondly, you have to realize that in order to do it, there is an overhead. And the third thing is, it is very difficult to collaborate on what you are doing as an agency as your real day job, which is the HTA itself. And you can see how long it's taken the journey for UNETA to get to that point. And even now, it's only a small component of our full HTA that has been agreed to be produced collaboratively. But where the more meaningful, perhaps, collaboration can take place because people feel comfortable is around process development, is around sharing of processes, to be able to both think about things on an individual country level, but maybe even to get very efficient across countries about the way that you do various processes of HTA, so that, as Dan said, those people who are having to submit information into the HTA process, that can be more effective. And the second thing is obviously on sort of methods, or how you go about the technical aspects of HTA. Those two things are very fruitful areas to start with, but you still have to do the first two, which is know why you're collaborating and make sure you have the resource. Otherwise, the collaboration is very, very difficult to continue with.
Thank you, Carol. And I think that you picture a really ideal framework in which, if you have similar process or in a structured way, and then common methodology, it's you create the window of opportunity as well, if I may use the term as well, for capacity being used from different areas, and that exchangeability of resources that can come into support perhaps certain areas of the world that may not have that capacity at that time, and support those efforts as Dan was referring earlier. Javier, you've been mentioning in the chat your experience with the Afro HTA, and I'm conscious of time as well, that we only have 5 minutes left. But I was thinking whether there is any learnings from that Afro HTA regional approach that might be of help to shape the discussion that we are having today as a key learning.
I don't think we have lessons yet, because this is a new initiative being set up and being led by African researchers and policymakers, and led by Cambridge. But they are basically looking at existing networks, trying to understand what the lessons are, what the success factors are. So your point about funding for the HTA Asia link is something that they clearly took on board. The point about having clear terms of reference to decide what's in, what's out, in terms of what they will collaborate on and what they will not, is also very much taken into account. So something of what Carol was saying in terms of the purpose and the funding, also taken into account. So it's a nascent initiative in a continent that is eager to learn, that is eager to understand what the value of HTA is, and in a country where scarcity is basically the norm in terms of human resources and in terms of being able to, conduct these conduct these assessments and put in place these systems. So I guess we'll have to wait a bit to see how they go, and they will clearly enlighten us in terms of their own experience. Thanks.
Fantastic. So this is a note for Consilium to take that on board for future sessions as that evolves. So I'm conscious that, Rosanna, you have your hand raised, and we are getting out of time, but I would like to bring you into the discussion, and if you have any questions or comments.
Thank you. Just 2 minutes. From the experience of the WHO Collaborating Center for Health Technology Management, in the last 16 years, we are more than ever sure that this is the time to building capacities. This is the time to transfer knowledge, not just through sophisticated models or frameworks, but with evidences collected from other countries and successful responses to needs. that's it. What in the collaborating regarding HTA, the priorities of the country or the region. Let's talk about a country selected. Let's select 3 countries and then ask them, the government, 2 or 1 priority, and show them through a training with evidence how much value in the impact measurements could bring the application of HTA. And then these evidences are very clear drivers to make a change in the decision making. Thank you very much, Patricia.
Thank you, Rosanna. And I think that all of us will agree with your point. Okay, so as I said, I think that we are just running out of time, but I would like to give all our panel the opportunity to have a final word if they wish so, before we close today's session, and perhaps Javier, starting with you.
Well, just wanted to thank you for the opportunity to talk about, the importance of systematic priority setting and deployment of HTA as a tool to solve some of the problems low and middle income countries are facing, and the importance of learning from the successes and the mistakes from high income countries, and vice versa. So great to feature this LMIC angle into the broader conversation. So very much appreciate that, and thank you very much.
Thank you, Javier. Dan, any thoughts, final thoughts?
I was too busy writing in the chat, sorry. So the value and impact of HTA is actually what we'll be discussing at next year's HTAI Global Policy Forum, because as we've all discussed, and even in these established settings, we really struggle to try to document what the benefits have been. So I think that really above all else, we should be thinking about how the tools of the trade, this is reflecting on something that Carol said, but how the tools of the trade can be used to most benefit these settings where an evaluation of priorities and potentially some level of formalization of an approach like this would make sense. But we have to be very respectful of the context in which these processes are implemented, to understand differences in cultural differences and differences in expectation, differences in political systems, to make sure that if something really is not fit for purpose, we're not trying to shoehorn it in.
Thank you, Dan. Very powerful statement, I think. Carol.
Yes, I'm not sure I can sum up in a couple of comments and observations, because we've just scratched the surface of this topic, haven't we? Yes, again in this session, I have come out of this conversation with a very strong feeling that there isn't one cookbook. It's not as straightforward as that, and maybe we have thought about it. We've got a set of tools, and then we just need to pick the right tools for any individual setting, understanding the concept, understanding the context. But I think it's more complicated than that. I think you can't just have a set of tools and go into a country and think HTA tools and think that it's going to be relatively straightforward to apply them. We might again have to, I say this every time, tear up the rule book and think again about how we are going to make best use of this wonderful asset we have, which is HTA, to do good across the globe. Let's perhaps that's the topic of another workshop.
Thank you, Carol. Eric?
Yeah, everybody said it brilliantly. I think for me, it's just about go slowly to go quickly, and really be very, very thoughtful about the in-country environment, the decision context, the problem to solve, what might the right tools be to solve that specific problem. That may or may not be HTA, or it may be a recipe in the cookbook from Carol of what HTA is. But HTA in itself will not be enough. There will need to be other sort of architecture around HTA, again, that's specific to the country to make it work.
Thank you. Important not to forget. And Vaya, last but definitely not least.
Well, I fully agree with Eric. I think HTA operates in a system, and the system perspective is key for countries. And I think indeed the question we should ask, I mean, we as a community, or is indeed, what are we trying to solve? What is the problem here? And I think the problem, the policy problem, should be the leading question. And that could, of course, differ from country to country, even within countries, within, you know, within regions of countries. So context, I think, is key. It always has been key. And I think we already know that HTA is not a blueprint, and that we really have to work with the countries to see what we can do. And to me, it's always a challenge when you go to a country to understand the context. And so for me, working with local people is the most important lesson that I have learned in my whole career. It's not for me to tell others what to do, it's just to ask questions. Questions that can be reflective for the decision makers and also for the people doing the HTA on the ground. So I think that's a learning, and I think that works pretty well. And what I really would like to envision is also about sharing knowledge together and building, you know, a more resilient systems in which HTA plays a key role, because I, of course, also believe in the approach. I would say HTA is an approach which is part of strengthening the health system. So thank you.
Oh, thank you so much, Vaya. And I think that we will all agree with your final point being the final for today's session. So I just wanted to say thank you so much to the panel and Javier for your insightful comments and for sharing your expertise and your experiences with all of us, and to all the attendees who have been here today attending this session and also participating. Thank you so much for coming along, and definitely thank you, Consilium, for organizing this session, which I think is very close to all our hearts. And thank you so much, and have a lovely rest of the week. See you soon. Bye.